Thank you, Dr. Egan. I anticipate that this topic, and especially Dr. Egan's presentation, have generated some thoughts and questions, and we're going to ask that you all defer those to a panel discussion, which we will have after all three speakers have had some time to be up here. Our next speaker is Dr. Steve Schaefer. It is my understanding that he was flying in from London. We have a 20-minute warning. Then I'm going to propose that we have a small, we just change our program lineup. And in that case, I'll introduce our next speaker. It's my privilege to introduce Dr. Alex Hannenberg. And to many of you who may be international, be interested to know that he was the president of the ASA in 2010. And that's an important year in the development of the ideas that led to the use of, or consideration of propofol use by non-anesthesiologists. In other words, this was a topic of discussion at that point. So we're privileged to have Dr. Hannenberg come and participate with us in this discussion. So Dr. Hannenberg, come on up.
Thank you, and good afternoon. I imagine I'm not the only one who saw my name on the program of this conference and was reminded of that wonderful Sesame Street feature, Which of These Doesn't Belong? Nonetheless, I congratulate the program chairs for giving me an opportunity to help put this in context. This is an issue in which there's actually a lot of context. If you can switch over the source, we'll be in good shape. So, as you heard, I was president of the American Society of Anesthesiologists a few years ago, and with that in mind, I want to remind you that what I say today is my own thinking about this and in no way reflects the policy or viewpoint of the ASA. Nonetheless, I had the opportunity from virtually the first day being elected an officer of ASA in 2004 to be embroiled, immersed, something like that in issues related to propofol and anesthesia for GI endoscopy, and learned quite a lot along the way. So that's what I'm going to try to share with you, although I don't know the first thing about pharmacokinetics or pharmacology, so that's why I'm the one who doesn't belong. Professional organizations here and abroad have had quite a lot to say about the use of propofol and administration of sedation by non-anesthesiologists because of the enormous economic implications of the issue. Health plans have both private and public have had quite a lot of policy making to do about this, federal and state agencies, and these are the ones, the FDA and Medicare in particular, that really have the greatest influence over what's done and what's not done in this area. And finally, I thought I'd wrap up with talking a little bit about what's going on in this area, and in particular with some attention to the economics of it, because I think that provides an explanation of why so many organizations, professional and regulatory and insurance, have taken the time and effort to speak to the issue. So as I said, virtually the first day I sat as an ASA officer on our administrative council, this was an agenda item. And I think the first thing that you will find striking if you know anything about American anesthesiology is that, to put it mildly, we are not in the habit of issuing statements jointly with the American Association of Nurse Anesthetists. So this is already a special occasion. And the statement says a couple of things and is very tightly aligned with the Food and Drug Administration's warning in the packet insert for Propofol since the day it was approved. But I want to call your attention in particular to the fact that this statement could have said Propofol should only be administered by nurse anesthetists or anesthesiologists. And it stops a wee bit short by talking about persons trained in the administration of general anesthesia. And while I think many people have taken those to be synonymous, I would suggest that there actually is a little bit of light between the two of them that could turn out to be important. Now, defining what that means, what is the knowledge base and the skill set that's required to safely administer propofol, moderate sedation, or deep sedation is a question that I always felt the whole wide world was waiting for anesthesiology to answer. And by the time in 2010, I became president, really felt very self-conscious and to a degree embarrassed by the fact that we weren't answering that question. And as Dr. Egan said, we're really abdicating that opportunity of being the source of the gospel on the use of propofol. Now, interestingly, last year at the House of Delegates, a revision to a statement about deep sedation was approved, and you might say that the ASA sort of dialed back, lowered the bar a little bit by saying it's not trained in the administration of general anesthesia anymore, it's trained in the medical practice of deep sedation. And that may reflect the fact that 2 years earlier, and we'll go into this in a little bit, ASA actually put a little bit of meat on the bones of the discussion about what does it mean to be qualified to administer deep sedation, and that I'm fairly proud of instigating. So if this is a moving target in American anesthesiology, it surely is just as rapidly a moving target in Europe, where in 2010 a collaborative of GI organizations, including nurses, as well as the European Society of Anesthesiologists, came up with a statement and a training outline that addressed this issue and by inference, recognized the phenomenon of non-anesthesiologist administration of propofol. And I can't tell you the number of times that this statement was kind of thrown in my face as a leader of ASA about how open-minded our European colleagues were on this subject of non-anesthesiologist propofol administration compared to ASA. But it ceased being thrown in my face just about exactly a year later, where I'm not sure whether you'd call 21 national organizations a renegade group, but a renegade group of anesthesiology organizations recanted on that consensus document and came out with a statement that I would argue is actually even more restrictive than the position that ASA is alleged to have taken. Now, one of the things that I've found most troublesome about making policy and declarations about sedation by non-anesthesiologists and propofol administration by non-anesthesiologists is the assertion that this is self-serving and driven by economic interests. And I'll talk a little bit about the economics, and you can draw your own conclusions about the degree to which what has happened is linked to the economics and business aspects of anesthesia practice. But I think before you conclude that is at the foundation of where we have been on policy around propofol and sedation, I'd call to your attention And I'll just give you a couple of illustrations of organizations that I think we can pretty fairly say don't care a whit about the income of anesthesiologists, who have taken positions in general more stringent than ASA has over the years. And the Institute for Safe Medication Practices is a not-for-profit, highly respected organization dealing with drug hazards, drug labeling, drug contamination, and so forth. And the statement you see before you again echoes the concepts originating in the package insert about being trained in the administration of deep sedation and general anesthesia. And this other point about the sedationist not being simultaneously involved in the procedure itself. And that concept that if you're doing a medical procedure, it deserves your full attention, as does the administration of the sedative or anesthetic, is the very heart of why we are a medical specialty. So ISMP focuses on those two key considerations, just like the joint ASA-AANA statement did. And the Quad ASF, which is one of 2 or 3 major national accrediting bodies for ambulatory surgery centers, actually is probably the most explicit and most restrictive by saying only by a nurse anesthetist or by an anesthesiologist, and doesn't get into this trained in the administration of general anesthesia or trained in sedation stuff. They take a pretty hard line on it, and again, arguably an organization that should be indifferent to the economic interests of anesthesiologists. Now, the beginning in 2000, 2001, it became evident that the increase in the frequency with which anesthesiologists were providing services for patients undergoing GI endoscopy was increasing at a really very dramatic rate. Between 2000 and 2005, Medicare claims for the 2 anesthesia codes related to these services were increasing at the rate of 20+% a year. And in fact, for several years running, made the list of the 100 most rapidly growing services under the Medicare program. And it may be in response to that, it may be in response to the consideration that the superiority of propofol administration or anesthesia care for GI endoscopy was not well established, that the American Society for Gastrointestinal Endoscopy came out with a statement, the routine assistance of an anesthesiologist for average risk patients undergoing standard upper and lower endoscopic procedures is not warranted and is cost prohibitive. And those 2 dynamics there, the type of the patient and the type of the procedure, rapidly saw their way into medical necessity policies by a number of major insurers around the country. And as you heard from Dr. Egan, Aetna was kind of back and forth about this over the period of a couple of years. And I think very concerned about access to screening endoscopy services for their enrollees, and I think hesitated to rock the boat much on that because as a health plan, their accreditation and ranking had a lot to do, has something to do with the access of their patients to these kinds of screening services. And I had the opportunity to speak to medical officers at Aetna and Anthem WellPoint and Medicare carriers and so forth about what when anesthesia services for endoscopy was medically necessary. And the premise from them was that it was not always necessary, and they based this to a large degree on the ASGE statement. But what I can tell you from the experience of having this dialogue with the health plans is that I really could not come up with an example of an extenuating circumstances that would justify the involvement of an anesthesiologist that they would not accept. And so certainly failed sedation on a prior occasion, seizure disorders, pregnancy, obesity, obstructive sleep apnea, airway anatomy. I really could not come up with anything that they would not say, okay, we'll cover that. So this is an excerpt from Anthem WellPoint is a carrier in about 11 or 12 Western states with a fairly substantial market share. So this is the kind of policy that they came up with. And for starters, the first line has to do with the fact that we're not talking about about availability of anesthesia services for therapeutic endoscopic procedures, prolonged procedures, ERCP, ultrasound, control of bleeding, et cetera. This is restricting the medical necessity criteria for anesthesia services for routine screening procedures, essentially, and then only restricting it for patients with essentially no complicating medical factors. Interestingly, the Medicare carrier for the New York, New Jersey metropolitan area took a different approach, which was they took the decision to use Propofol, which they didn't really address, as kind of per se evidence of medical necessity of an anesthesiologist's participation. And when you saw the fact that about 50% of GI endoscopy procedures in the Northeast are associated with an anesthesia claim, that has a lot to do with the prevalent practices in the New York, New Jersey metropolitan area, because I can tell you where I practice in Boston, it is not 50% or anywhere near that. So I think this policy and ones like it in that area among insurers has a lot to do with the very dramatic variation around the country. So here they say if Propofol, then an anesthesiologist, a segment of the GI community, and I agree with the prior speaker, I think it's unlikely that Dr. Rex and Dr. Vargo and their ilk represent the vast majority of gastroenterologists, but they say Propofol without an anesthesiologist is the preferred method of caring for GI endoscopy patients. And this is a paper that published in 2009, just shortly before I appeared in front of a room of about 6,000 gastroenterologists, along with Dr. Rex. And to discuss this, and the point I made was, and as I said, there's a lot wrong with this paper, which I think all of you probably understand better than I. But from my point of view, at least the American centers contributing cases to this 600,000 case meta-analysis were operating in defiance of FDA, CMS, State Nursing Board, and so forth regulations. So what would you do if you were using a drug essentially illegally? You'd be damn careful about how you used it, and you'd train very carefully. And so the intellectual leap from saying our observation of patient outcomes under those circumstances would be the same outcomes and practices in the absence of all of that regulatory environment, I think is the fundamental and fatal flaw to what Rex and Vargo are telling us. This is a few years old, and I'm not sure, I doubt that many nursing boards have rolled back their prohibitions on RNs. We're not talking about nurse anesthetists, RNs administering Propofol. In fact, I rather suspect that other nursing boards have jumped on the bandwagon. But this, as you'll see in just a moment, is a very important consideration. Remember that the Food and Drug Administration in particular, as well as some private groups, the FDA says that the individual administering Propofol cannot be involved in the conduct of the procedure. So who else is in the room? right? And so they're prohibited by inference under the FDA package warning and even more explicitly by state laws and nursing regulations. Now, there was a lot made of this December 2009 Medicare Conditions of Participation Interpretive Guideline. And before I talk about this, let me just explain what an interpretive guideline is. So sort of in the federal rulemaking and regulation world, there's a hierarchy. The statute, the thing the Congress passes, authorizes executive branch agencies to make regulations. There's a bunch of rules around how they make those regulations, including that they need to be published in the Federal Register for public comment. Those public comments need to be considered, and a final rule is then published. So you've then got the Code of Federal Regulations, and in this case called the Conditions of Participation. Conditions of participation means conditions of participation in the Medicare program, as in if you don't meet those conditions, you can't take money from Medicare. So hospitals and other facilities take that very seriously. When you get surveyed by your state health department, by the Joint Commission, by DNV, or by CMS itself, you are being surveyed in large part on the question of whether you are meeting those conditions of participation or not. In order to facilitate the survey, the agency publishes these interpretive guidelines, which for a close approximation would be a surveyor handbook. That is not subject to the administrative procedure rules about publication in the Federal Register and public comment and so forth. So on December 11th, 2009, about a month after I became ASA president, the CMS came out with these interpretive guidelines out of the blue. They were important in a number of respects, but I think some aspects have been widely misinterpreted, including by Dr. Rex. I've highlighted 3 bullets on this slide and then 1 item on the next that I think are the important features there. The first one, I would say, is a victory for anesthesiology. That is to say that all sedation and anesthesia services in a facility and all of its sites and licensees must be under a single anesthesia department headed by a physician. So that gives anesthesiologists an awful lot of influence about how sedation and anesthesia is practiced. The second bullet, again, this is interpretive guidelines. The second bullet is very close to a verbatim extract from the overlying regulation. General anesthesia, regional anesthesia, monitoring anesthesia care, including deep sedation and analgesia, may be administered by an anesthesiologist, a non-anesthesiologist, MD or DO. So Dr. Rex, in response to this, wrote a paper in the Annals of Internal Medicine saying CMS has forbidden gastroenterologists from administering propofol and deep sedation. That is absolutely not the case. CMS, just generally speaking, does not distinguish one specialty in medicine from another. They lump all doctors together. So there are problems for Dr. Rex and his practice in these CMS regulations, but what he's saying is not the problem. The problem is that in that paragraph, registered nurses are not recognized as individuals authorized to administer deep sedation or general anesthesia. Now you may be saying, well, we just heard that sedation